Prices, it's not that much. And I will put it in a poly.
Camera. Thank you. Good morning, everyone. My name is Kelly Sandacre. I'm your SURSAC administrator today. I'm glad everybody can make it this morning. I'm going to go ahead and go through our meeting logistics and reminders for this morning. This meeting is being recorded and live streamed on TVW. The meeting recording will be shared on the HCA website on a page dedicated to SURSAC meeting information. The meeting recording is open to the public disclosure requests. Please do not disclose any private or confidential information. We will no longer use a verbal roll call so that we may use that time for other agenda items. However, we ask SURSAC members that you take a moment to enter your full name and the area of representation you serve on the committee into the chat so we can all be reminded of the wide range of representation we have on the committee. Language and terminology. Use people first language, i.e. person experiencing homelessness rather than homeless person. Use the term substance use rather than substance abuse or addiction, which is stigmatizing. Avoid using the term addict, person first language alternative, person with a substance use disorder, or person who uses drugs. When someone forgets to use these terms, assume that their intent is still good and be gentle with reminders to use agreed upon language. Guidelines for public feedback. We will usually allocate 10 minutes at the beginning of the meeting and 5 more minutes near the end of the meeting for public comment. I don't know if I'm sharing. I don't think I'm sharing the screen. All right, go back to this. Avoid, yeah, each person will have 3 minutes to provide feedback. Public comment on each agenda item will be invited after the committee has provided its comments. Ensure dedicated time for public comment input before moving to the next item. If you are not a committee member and would like to comment during a discussion, please raise your hand to bring it to the facilitator's attention. Feedback that is not provided during the meeting can be submitted via email at any time to hcaesb54676@hca.wa.gov. All right, and now I'll pass it over to Tony.
Yeah, good morning, everyone. My name is Tony Walton. I'm a section manager within the Division of Behavioral Health and Recovery and chair for this meeting. wanted to welcome everyone and thank you for making time to attend today's meeting. We have a jam-packed agenda like most meetings. We're going to have a full legislative update later, but I just wanted to flag a couple legislation that this committee has talked about, specifically 1574. That was the bill that would make updates to our state's Good Samaritan law. We've had conversations about that bill in the past. And as a reminder, legislative session ended on April 27th. So where we're at today with the update from Sean O'Neill later this morning will be a summary of kind of some of the highlights. And I think Sean might speak to this, but 1574 did not pass. We were watching that one closely because it did tie directly with the recommendation that came out of the committee, specifically around expanding the coverage of the Good Samaritan law in Washington State. Another piece of legislation that was introduced towards the end was 5809, and that was legislation actually would have ended SURSAC. It basically kind of rescinded the authorizing RCW for the committee. That bill did not gain any momentum. It did not make its way through the legislature, and so ended up effectively dying. But thought I would flag that for everyone today. And then I know everyone has been watching the outcome with Recovery Navigator program funding closely, but in case you haven't had a chance to look through the hundreds of pages of the operating budget and agency detail information, Recovery Navigator program was reduced effectively by 20%. So it wasn't a full elimination. But it was reduced from the current funding level of $24.5 million per year down to whatever 20% off of that is. I think around 19 million, 18 to 19 million per year. Sean's going to get into that a little bit more, but I just wanted to kind of highlight that just in case somebody wasn't able to stay for the entire meeting. Another thing I wanted to talk about real quick, and just covering the agenda, just to remind everyone, do we have the agenda in the chat? Can we?
I can share it.
Yeah, we'll put the agenda in the chat, but we are going to also provide some updates today on the substance use disorder intake screening and assessment work group, as well as the safe supply work group. And then we have guests from research and data analysis over at our partner agency, Department of Social Health and Services, giving an update on some of the statewide simple possession charges and what we're seeing across the state. Tasha Fox came a month or two ago and provided a summary, and we've updated that with some additional information based on questions and feedback. And then finally, we're going to end like we do every meeting with a presentation from Greater Columbia on their Recovery Navigator program. The only other HCA announcement that I wanted to cover, I'm actually going to pass off to Sarah Melfi-Klein to make sure everyone in the committee, as well as our guests and other attendees, are aware of work that's happening at the Healthcare Authority in regards to post-overdose support. So Sarah, if you're ready, I'm going to pass it over to you.
I am. Can everybody hear me?
Yeah, absolutely.
Great, thank you. Hi all, Sarah Melfi-Klein with the Healthcare Authority, Division of Behavioral Health and Recovery. Usually I'm there in the room, but joining from home today. But I just wanted to share quickly about a project that we're doing, as Tony mentioned, in the world of post-overdose support. So Healthcare Authority has contracted with Health Management Associates, or HMA, to build a toolkit for families and loved ones to support them in the aftermath of someone who's recently survived an overdose. Non-fatal overdoses are common, and the aftermath can be a very vulnerable time, and also one that presents an opportunity for education and support in order to mitigate the risk of subsequent potentially fatal overdoses. So we wanted to put together a resource to empower loved ones and community members through education and support to be equipped to help in navigating the aftermath of an overdose in order to widen that safety net. We plan to have a draft of this toolkit by June 30th and launch in time for International Overdose Awareness Day on August 31st. And so we're currently kind of in the research, gathering, interview stages, prioritizing interviews with those with lived experience, secondly, those with professional experience. And of course, we are on a tight timeline, as I mentioned. So if you do have ideas of anyone who should be interviewed to inform the development of this toolkit, I'd ask that you reach out as soon as possible. Today, preferably to myself or Sarah Deutsch, my colleague who's supporting on this, so that we can get those over to our affiliates at Health Management Associates who are conducting the interviews. And I will put our contact information in the chat just after this. There are stipends available for those with lived experience who are contributing to the toolkit. And just kind of another note on how this ties back to the work of the committee is that we do hope to share this resource widely across programs that HCA and other state agencies manage, including programs this committee has supported in consultation, to again add that additional crucial layer of family and community support to the works that programs are doing directly with individuals at risk of an overdose. So with that, I will pass it back to those in the room. And again, I'll put mine and Sarah Deutsch's information in the chat if you have ideas of individuals or organizations who can support in the development of this toolkit. Thanks.
Awesome. Thanks so much, Sarah. And, once please provide feedback, reach out to Sarah. And, if you have any thoughts, and then also if the committee is interested, we could come back in July or August and kind of do a walkthrough of the toolkit and kind of share like what were some of the outcomes and what was some of the content included. Sarah Deutsch and Sarah Melfi-Klein have done a great job in kind of preparing and including others and bringing in lots of voices and thoughts. And so excited to see where that lands. With that, I think that's it for HCA announcements. We're going to kind of move on because we do have a lot to cover today. And so, Blake, I'll throw it over to you.
All right. Thank you, Tony. Hi, folks. Blake Olson with HCA here. We are at this time going to take committee member announcements or comments if there are any. Again, this is for committee members to let us know if they have anything special that's going on that they want to tell us about, or just have comments in general. So again, looking for committee members for any announcements, etc. Okay. See no hands. Last call. Okay. Next up, public comments. We'll take any comments from members of the public, non-committee members to address anything they want to address. So if you could raise your hand in virtually, that would be great. Called on. So public comment. See no hands. Actually, Kelly.
Hi, I don't know if this is the right place to say this, but we do have an upcoming training that I was hoping to let people know about. Is this the right place?
Sure,
Yeah,
go ahead.
absolutely.
Okay, I'm just going to put it into the chat, but that we are doing a series around stimulant use disorders, and we're doing a stimulant symposium on coming up as part of the CEDAR team, and I'll put more information in the chat about those upcoming trainings if anybody's interested.
All right. Thank you, Kelly. Appreciate that. All right. Anybody else? All right. Looks like we have no hands. So, Tony, I'm going to throw it back to you to introduce Sean, if you don't mind.
Oh, yeah, definitely. We're a little ahead of schedule now, so let me just make sure Sean's here.
I am here.
Oh, wonderful. Sean, thanks so much for taking time today to provide a kind of update, an update regarding the legislative session and what we've seen now that we've had a little over a week, I guess 2 weeks now, to kind of digest and understand.
Oh, no, just a week.
Is it just a week?
Just a week, yeah.
All right, so just a week.
And it is.
So Sean, yeah, I'll pass it over to you, Sean.
Yeah, no worries. Thanks so much. And thanks for the invite this morning. And for those of you that don't know me, my name is Sean O'Neill, and I'm the Legislative Relations Manager here at the Healthcare Authority. And so we have just been done with legislative session. Sine Die was last Sunday, so a week. And honestly, we are still in budget analysis mode. It takes us a couple of weeks and even then some to really dive into the budget and figure out all the implications for the agency. So I'm going to do an overview of the legislative session, and I'll let you know the order that I'm going to go in, and then just kind of like how I like to run these things, which are spoiler alert, is pretty casually. I'm going to, a couple of bills were sent over as desired coverings by the SURSAC. And so I'm going to go over those bills. And then I'm going to go over other behavioral health bills. And then I'm going to go through the budget. And these will all be pretty high level overviews. And I tend to go pretty quickly. So feel free to interrupt by either raising your hand or just shouting at me or putting something in the chat. Don't mind that at all. And feel free to ask any questions. I may or may not have the answer, but usually can get a turnaround time pretty quickly. And also I will, at the end, I will put my email in the chat, and feel free, if you don't want to ask a question in the public setting, feel free to shoot me an email afterwards. All roads are acceptable. So with that, if there are any questions to start off, and if not, I will jump right in. All right. So first thing I'm going to go over are the bills that you guys sent over that you wanted to talk about. So going to start with 5361, which is the ASAM delay. And that one is pretty simple. It passed. It didn't have any issues. And it is going to delay the implementation of ASAM 4 until January 1 of 2028. And there's a couple of reasons for this bill. One is I think the state just wasn't quite ready to fully implement. The other was in the budget situation. It did realize about $10 million in savings. And that's a good reminder. I should probably level set where we're at right now. So the budget has been passed by the legislature. It is currently being analyzed by the governor's office, and the governor has until May 20th to sign it. And so pretty much all the bills at this point, including the budget, are what's called 20-day post-session bills. And so that's minus Sundays. And so we should see everything signed by May 20th. I know that bill signings are coming in volume. I get notifications every day of bills that are getting signed, and so and then probably anticipate the budget being one of the last ones, just because it is. I think it's about a 1,200 page document or something like that. So it does take a little bit of time to comb through all that. So back to the bills, but I thought it'd be good to go over those process questions. As Tony alluded to earlier, 1574, which was the expansion of the state's Good Samaritan law, that did not pass. It's also important to know that bills that are introduced in a long session, and that's what this is, are technically still alive for the following session. So they revert back to the, now I'm testing my knowledge here. If there's a legislator on, they might correct me, but I think they revert back to the last committee that they were in the House of Origin. And so 1574, the Good Samaritan law, would go back to the House Judiciary Committee or Law and Justice Committee. But it does not need to be reintroduced for the following session. Yeah, that one did not make it through. 1811 is a bill that has the UW School of Social Work start a training academy for co-response. And that passed and made it through the process. It also changes the definition of frontline employees to include co-responders for liability reasons. So 1811 passed. 1391, which I believe is the youth sentencing alternatives, youth diversion. Very, very little HCA impact on that one, but that one did. Rep Davis, they revert to Rules Committee in the House of Origin if they made it that far. The Good Samaritan Law reverts back to that. And so 1391, thank you very much, Rep Davis. 1391, which is the youth sentencing alternatives, that one passed and I think went absolutely with almost no opposition. And then 1427, which is, speaking of Rep Davis, is Rep Davis's peers bill. That one passed as well, and HCA was funded to do the work. And just as a reminder, what that bill does is it has HCA contract for some technical assistance to organizations around the state so that they can better and more effectively bill for peer services. And it also has us doing 3 different trainings. And so we will do trainings on some peers work. And actually it has us start the work for those trainings. I don't think that it actually funds putting those trainings out there yet. And so, but it does have us do the technical assistance portion, and then it also changes the name of the peers from certified peer specialist to now that I'm on the spot, I cannot remember the next name, but it's CPSS, I believe, is the acronym, and I'm sure someone can also put that into chat. Yeah, so that bill did pass and make it the way through, and it was also reflected in the budget, which is also on any bill that has a fiscal note, to have it doubly reflected in the budget is always a good thing. Any questions there? Certified peer support specialist, that's right. I had the letters right, but I could not recall what the 2 S's were.
And Sean, just adding with 1427, it might be of interest to the committee and others that the work where HCA is going to contract with an organization in terms of giving recommendations about how to bill for peer services, there's a specific call out for Recovery Navigator Program lead and arrest and jail alternative within that for that organization to make recommendations specifically around how to bill for the work happening underneath our pre-booking diversion umbrella in Washington State to better find ways to leverage Medicaid to cover the costs of those services.
Excellent. All right, any questions before I start moving on to other bills? Okay, so diving into the broader sweep of behavioral health bills, there's House Bill 1813, and this has to do with reprocurement of our managed care contracts, and especially how that relates to crisis services. So it requires HCA to adjust Medicaid rates and reflect increases and decreases in services, facilities, and capacity. It has us prep for the reprocurement of our managed care contracts to ensure that crisis services that those contracts reflect network adequacy and cost. And it also directs HCA to expand delegated arrangements with behavioral health administrative BHASOs for crisis services. And we will also develop a plan for statewide BHO that serves our tribal partners, so American Indians and Alaska Natives. And so that was a Rep Macri bill and had a whole lot of work on it through the session. And so, yeah, that one is sitting in front of the governor at this point and also was likewise reflected in the budget. There's House Bill 1432, and that applies more to commercial health plans, including our PEB and SEP plans. It codifies clinical standards for medical necessity determinations, and it applies ASAM criteria to those plans. And then there is 5745, and what that does is it allows counties to elect to have HCA contract with the Office of Public Defense for counsel services for individuals that are being detained through the state ITA law. And so that, and there's also some funding there to allow for defense counsel. Let's see here. And then I've got a lot of notes. And so any questions there before I move on and kind of switch gears just a little bit? Okay, HCA had 4 agency request bills, and all 4 of those bills did pass and make it through to the governor's desk. And 1 of them have been signed, and 3 of them are still waiting. So waiting on the one that has been signed, and I'm going to go over these fast because they're not necessarily all behavioral health related, but they are reflect a lot of work for the agency. So there's a care coordination bill, House Bill 1287, that's been signed, and that aligns data disclosure permissions for licensed mental health counselors, marriage and family therapists, and social workers, so that they can also, without express written consent, information share with a patient's other providers. And that's super important upon discharge from acute hospital setting. And then we had a PEB and SEP access and affordability that caps the rate that the PEB and SEP plans pay to inpatient hospital stays. And it also establishes a reimbursement floor for behavioral health services at 150%, also for primary care services, but at 150% of the Medicare rate. That was probably our biggest lift this session. And then we had an APCD bill that has some data disclosure requirements that passed, and then a very good little bill on PEB and SEP benefit alignment that also passed. Any questions there on agency request legislation? Okay. Let's move on to some budget issues. So top level budget issues, as everyone I'm sure is very aware, this was an extremely tight budget session. And we're probably looking at a couple of these in a row is the best estimate that I have heard. And so that's the bad news. The good news is the budget, while I'm not going to say is perfect, is and does have some tough things. For HCA and for our programs, it was not nearly as painful as it could have been, and the cuts were not nearly as deep as many of the first passes at the budget included. So broadly, HCA is going to have 6% across the board admin reductions. And so that's contracts, goods and services, management staff, and travel. So the good news is that we think that can be managed through our existing vacancy rate and retirements and all that stuff as far as the FTE portion of that. That's at least our preliminary analysis, and then the other stuff like goods and services and travel, pretty self-explanatory. But things like the Medicaid transformation project, that's our 1115 waiver, was fully funded or nearly fully funded, and some pretty deep cuts that were originally considered, including like moving age blind and disabled from managed care to fee for service. That's a very high intensity population and who use a lot of care coordination services. And so it would have been pretty difficult to move them over to fee for service without some major pain to those folks. And so that was not included in the final budget. There were, like mentioned, some painful things like 1% across the board Medicaid managed care rate reduction. And so that's likely to translate to a 1% reduction in provider reimbursement. And then there's adult and children dental rate reductions. I think that's where the deepest cuts were. And then Medicaid lab rate reductions across the board. But so just high level stuff there. Now let's delve into some of the more behavioral health specific areas. I can pause for questions for just a moment before. Okay. So I'm going to do this much like I did the policy bills. I'm going to do some more targeted items of interest around Blake funding, and then I'm going to move to the broader behavioral health implications on the budget. And again, feel free to stop anytime and ask questions or clarifications. So the Blake administration budget administrative funding did take a $1.1 million reduction. And health engagement hubs, they picked up the underspend on that. So I think we were underspent by about $500,000. And so they swept that underspend. The CJTA short-term housing vouchers, I think that also was a $3.5 million reduction. Arrest and jail alternatives was reduced by 10%. LEAD was reduced by 10%, and recovery navigators reduced by 20%. One note on that, I think the Senate budget actually had recovery navigators eliminated, and the governor's budget had that reduced by 50%. So while 20% I know is a significant reduction, it does represent an increase from 2 out of the 3 proposed budgets. So not as bad as it could have been. Also, funding was provided to continue the long-term effectiveness study for RNP and LEAD. So that study is being done by WISIP. And then BHASO's SUD Recovery Services Regional Administration, that was reduced by 50%. And so any questions there before I move on? Okay, broader behavioral health items. Okay. Okay, so Short-term housing subsidies and supports for individuals with mental health, that was reduced by 5.3 million. That represents a 20% reduction. And then targeted behavioral health housing grants, that was reduced by $400,000. Jail behavioral health medications. So the funding was provided to increase grants on that one to provide access to medication for opioid and alcohol use disorders in jail. Ongoing state funding was reduced by 1.5 million. But I believe that was transitioned to a different account. So it was I think that was actually a reduction in the increase. And then going through these here, I already mentioned that funding was provided to implement 1427. A PPW facility in Grace Harbor County was cut, and that was a savings of $3.4 million. That's pregnant parenting women. That was an SUD facility in McCleary, I believe. We couldn't find a contractor. There was a reduction of 50% to the ongoing funding for public health dispensing machines. So that is the dispensing machines that we're going to have naloxone, fentanyl test strips, and other public health supplies on them. Recovery residences, funding for those were reduced by 10%. That reflects a $1.0 million reduction. And yeah, that is the broad overview. I said I was going to go fast. I know that was a lot of in House Bill 2015. You'll have to, I don't have all the numbers memorized. So let me see what that is.
So just for the purpose of the recording, Susan PC asked, I'm interested in hearing more about engrossed substitute House Bill 2015 and how it relates to Recovery Navigator programs.
I don't know off the top of my head. I will have to get back to you. So, Susan, what was the percent of the reduction? Yes, 50% reduction in funding for the dispensing machines. And I'm writing a note to get back to Susan on 2015 implementation. Okay. And I see you with her hand up.
Yeah, hi everyone. This is Susan PC. I am the Recovery Navigator Administrator for King ASO. And yeah, I don't know all the details about the bill, but it is the House bill that creates $100 million for local law enforcement. And as it was explained to me, but I have not read, so I don't know the implications or the details, that RNP was mentioned specifically as a possibility for law enforcement agencies to apply for grants. I was just wondering if there was any more details on that. And that was my question. And if we don't know, that's fine. I just wanted to clarify. Thanks.
Yeah, I will have to get back on that. I don't know that our analysis is that deep yet on 2015. And so we'll need to get back to you.
Is that
Thank you.
Emily?
And then I saw Emily with a hand up. And I'm sorry if I
I
mispronounced.
just want to make sure Representative Davis isn't responding to what Susan just said. I don't want to interrupt that if that's.
And I see Rep. Davis.
Do you want me to answer Susan's question?
Yeah, would love to. Love for you to.
Yeah, so I got to check. So the Senate did make some changes to that bill, but my understanding is that the $100 million is strictly for law enforcement. However, the bill contained a local taxing authority. So right now, cities and counties have the authority to put on the ballot for all of their voters up to 0.3% sales tax for public safety. When it has gone to the voters, that hasn't always gone well. It failed in King County some years ago. Snohomish County tried a 0.2% sales tax. I believe it was just last year, and that failed. But what 2015 does is it provides the same authority for that basically public safety sales tax as the authority that currently exists for the 0.1% behavioral health sales tax or the 0.1% housing affordability sales tax, where it can be done on a councilmatic basis. So I know Susan knows this, but for anybody else, who might be less familiar, basically that means, just the 3 county commissioners or in King County, 9 county council members, they can vote amongst themselves to increase the tax without having to go to a vote of the people. Outside of King County, tax increases are not always the most well received by the public. And so, we saw broad adoption with the 0.1% behavioral health sales tax, with the legislature enacted, gosh, I want to say like in 2005 or 6. Most counties have adopted that. And so the hope would be most counties would adopt this public safety sales tax. And there's a very broad list of enumerated uses for that public safety sales tax. And that includes all sorts of alternative response type of, sort of recovery navigator, co-responder programs, et cetera. But that authority for those expenditures, again, come out of that taxing authority that has to be passed at the local level, not out of the $100 million. It's also noteworthy that $100 million is only one time grant authority. And then there's also a budget note in the 20% Recovery Navigator program reduction that basically implores local jurisdictions to contemplate backfilling the 20% haircut with local dollars. And this public safety sales tax would be one potential way they could do that.
Appreciate the explanation. Then I see Susan. Please go ahead.
Hi, this is Susan PC again. I just wanted to say thank you. That was a very thorough explanation, and I really appreciate it. Thanks.
All right. Any other questions?
We want to go back to Emily. I believe Emily had her hand up. Sean?
Oh, Emily just was making sure that I saw that Rep. Davis had her hand up, I think.
No, I was letting Rep. Davis speak ahead of me because it was related to the
Oh,
conversation.
sorry.
But I had something different to say.
Sorry, misunderstood that.
Related to the naloxone dispensing machines, just want folks to be aware that the overall proposed budget in the conference budget for naloxone is about $9 million less over the biennium than what we've had this current biennium. So the Washington State Overdose Education and Naloxone Distribution Program will have to be kind of considering how we manage that reduction. There's some prioritization we may need to do or look at increased use of intramuscular naloxone, which is much less expensive than nasal naloxone. More to come, of course, but just want folks to be aware of that. And we've also been managing the dispensing machine work through an interagency agreement with HCA. So we'll also have to chat together and think about kind of the priorities for that, reduction in funding and how we make the best use of what's available. So just want folks to be aware of that as we move into July.
We have Rep Davis as well there.
Yeah, thank you, and thanks, Emily, first of all, for letting me leapfrog ahead of you. But now I have actually a thought in response to what Emily just shared. So I had a bill several years ago in 2021. It was Senate Bill 5555, and the having to do with naloxone. It did a number of things. I'm sure Emily's well familiar, including requiring behavioral health agencies to dispense naloxone, make sure all of their patients or clients have a kit. But one of the other things that it did is it set the state on a path. I believe we would be the first state in the country to basically have the state do bulk purchasing of naloxone. And I specifically modeled it after the vaccine distribution model for the state, where there's this bulk sort of purchasing infrastructure and distribution through networks, and then I believe cost sharing across insurance carriers. But the idea of the state getting involved in that sort of bulk purchasing or bulk sourcing creates opportunities for cost savings and to make our money go further. So I wonder if it might be prudent. The bill, there was some anxiety on behalf of the Department of Health and the Healthcare Authority at the time in 2021, apprehension about how quickly they could stand something like that up because it was pretty novel and we hadn't used that structure for anything outside of vaccines. But I wonder if it might be prudent to get an update at an upcoming SURSAC meeting from HCA and DOH regarding where we're at with that bulk purchasing scheme, because since there's such a significant funding reduction, it might be prudent to start trying to row our oars in that direction. I believe the same year there was a bill passed. I think it was a Senator Kaiser bill, but I can look up the bill number, that had to do with looking at the state, sort of being its own pharmacy for certain medications. So the state actually potentially producing medications, and that would be. I know nothing about biochemistry, but that might be another possibility to that could be adjacent to this bulk purchasing concept.
Yeah, absolutely. And I know the Healthcare Authority has submitted a couple of legislative reports regarding 5195 and bulk purchasing and a decision package. I think maybe 2 decision packages, and those decision packages to help get the startup funding needed for bulk purchasing have not been funded yet. But we can definitely have our pharmacy team, who's kind of leading that work, come back to a future meeting and talk about kind of what bulk purchasing looks like and at least what the plan is. And if we were able to find the money from some other source or receive additional funding next legislative session, can definitely do that. I know there's a plan in place. And yeah, we can definitely include the link to those decision packages. I think they should be still on the OFM website. I'll double check, but we can include those with the notes. It looks like Emily put the bulk purchasing legislative report in the chat in the meantime.
All right. Well, thank you, Sean. I don't see any other questions.
Real quick, Sean, and just for everyone's awareness, like the budget still has to be approved by the governor. Is that correct?
Okay. Yep. So he has until May 20th to sign all the bills, including the budget that passed during the legislative session.
And he has certain veto power with the budget.
Any bill, he has. So Washington State does have line item veto authority, and so the governor, as they approve bills, can veto sections of a passed bill, including the budget.
Awesome. Thank you so much, and thank you for making time.
Of course.
Tons of information, a lot of legislation passed, and a lot of budget implications, and appreciate you sharing that with the group.
Yeah, absolutely. Thanks for having me. Really appreciate it.
And Sean's contact information is in the chat in case anybody wants to reach out directly if they had a question that they wanted to follow up on. Before we, Blake, real quick, before we move on to the next agenda item, I just wanted to kind of note a couple of things that happened in the chat while Sean was giving a presentation. One, and just really appreciate this. I think it's a perfect example of why this committee is important in creating space for these conversations. Don Pitts noted that, and I'll just quote Don for purpose of those that don't have access to the chat. Don indicated, I wanted to say that a post-overdose toolkit would be so incredibly helpful to those assisting a loved one after overdose. It personally could have changed the outcome for my son, who ultimately passed away from an overdose 4 months after having his first one. Thank you for the work being done to create a toolkit. And so this was in response to Sarah Melfi-Klein's update about efforts underway between HCA and partnering with DOH and others in developing a post-overdose support toolkit. And Don, I just wanted to, first just offer condolences and support for having lost a loved one to overdose. And also thank you for sharing. I know it takes a certain level of vulnerability, sharing that in a public space like this. And it's just so important just to know that the work that we're working on and the hours that we put into this, that we get that feedback, and we also have participation and getting your voice included in that process. And so really appreciate Sarah Melfi-Klein providing contact information and making that connection. And so please feel free to reach out. And again, just thanks for being here, and sorry for your loss, and thanks for taking time to share your experience and how it could inform the toolkit.
All right, thank you, Tony.
Yeah, and then just one other thing, Chloe Wilkins shared an upcoming training opportunity for community reinforcement and family training for craft. And we can get that in the notes when we send out the notes in case somebody doesn't have access to the chat currently as well. So we'll make sure to capture all of that. Okay, great presentation, great conversation. Appreciate everyone's questions and the additional information from Emily and Rep Davis. And I'll pass it over to you, Blake. Thanks.
Yeah, you bet. Kelly, you are up for an update.
I am. All right, good morning, everybody. My name is Kelly Sandacre. I'm the SURSAC administrator, but along with my SURSAC duties, I'm,
You do window, and then you can pull up like,
yeah. There we go. There we go. All right, thank you, Michelle. Good morning, everybody. My name is Kelly. I'm the SURSAC administrator, but I'm also, I was the administrator for SEDISA for where it stands, and also Safe Supply Work Group updates. I'll be saying today I'll be going over where those work groups are and what we're doing with them. And so I'm going to next slide. Agenda for today, SEDISA Work Group Overview, SEDISA Key Recommendations, Second Substitute House Bill 1427, Safe Supply Work Group Overview, Safer Supply Recommendations, where is the Safe Supply Work Group today, and questions, if anybody has any. ASAM 4th Edition, House Bill 5361. The work group reviewed the length of the SUD assessment and explored opportunities to shorten the process. The ASAM 4th Edition criteria introduced a new level of care assessment designated to expedite treatment initiation. Adoption across Washington State, including by HCA, is scheduled for 2028 in alignment with the House Bill 5361 2025, which is currently with the governor's office for signature. When I updated this slide, it was like last Wednesday, so I haven't checked about House Bill 5361, so I don't know if it's still sitting with the governor or if he signed it yet. But as far as when I last checked, it was sitting with the governor's office. As these systematic changes are expected to address many existing barriers related to assessment length, the work group has shifted its focus to identifying additional strategies to make the SUD intake screening and assessment process as low barrier and person-centered as possible. And so when I wrote this part, this is when the work group was meeting and such. So I'm going to go to the next slide and I'll The substance use disorder intake screening and assessment, SEDISA. Kickoff meeting was December 4th, 2023. We had bi-monthly 90-minute meetings. Final report submitted to legislators January 25th, 2025. The SEDISA work group is not currently meeting. However, HCA's internal SEDISA steering committee continues to meet and is actively discussing how HCA can advance the work group's recommendations without requiring additional legislation. And these are the recommendations that were made by SEDISA: increasing Medicaid reimbursement for SUD providers, anticipated impact, workforce expansion, shorter wait times, improved access to assessment and treatment. Statewide campaign for providers to clarify current intake screening and assessment requirements. More providers using up-to-date assessment process, i.e. removal of unnecessary steps and paperwork, leading to more efficient patient screening, intake, and assessment process. Widening the workforce that can treat SUD. Expand peer service pre-assessments, increase show rates for assessments, increase engagement before and after assessments. Enhance virtual access to assessments, improve accessibility and reach, especially among rural and low-income communities facing transit challenges. So out of scouring through the bills and such, what we found was, because the work group submits it to the legislation, and then they determine what they're going to do with those recommendations. And what we found was second substitute House Bill 1427, and it calls out a very specific item where it does match up with one of our recommendations, which is about peer support specialists, to make it a billable service. Develop it doesn't say make it a billable service. I'm about to read it. Develop a proposal to establish the concept of and billing mechanism for substance use disorder peer-run respite centers that are modeled after the mental health peer-run respite centers established under RCW 71.24649, and explore options for health carriers to pay for peer support services through what's that word? See that, Tony? Let's see. I can't read it. Read it off my screen.
Sorry, which one?
Services through this would be capitated payment.
Oh, capitated. Yeah.
Okay, capitated payment arrangements rather than an on-fee for service basis. By November 1st, 2026, the contracted entity or entity shall submit reports to authorities to describe the type and quantity of technical assistance they have been provided, the proposals that have been developed, and the trends in health carriers providing payment for peer support services, and any policy or budget recommendations to encourage health carriers to reimburse providers for peer support services. That is a lot of legal stuff. Hey, Tony, correct me if I'm wrong, but basically how I'm reading this is that people are going to start, the HCA or somebody is going to investigate how we can make peer support services a billable thing.
Yeah, I mean, they're already billable through Medicaid.
Yeah.
And so just making sure that we're looking for every opportunity. And the reason why we included this within the update is because it directly related to one of the recommendations that came out of SEDISA. So I think that was a coincidence, or maybe, I don't know, Rep. Davis could tell us if that was in response to the recommendations, but I think it just happened to be a good sequence of events that the recommendation that came out of the SEDISA work group, that 1427, kind of addressed some of those specific ideas that the work group is working on.
Thanks, Tony. Safer supply work group updates. So these were the safer supply recommendations. Recommendation 1, remove barriers to the implementation of randomized clinical trials or of safer supply for people with opiate use disorder in Washington. Recommendation 2, propose state legislation establishing a scalable safer supply pilot program. Recommendation 3, enhance and expand existing harm reduction and substance disorder treatment services statewide. Where is the Safer Supply Work Group today? So as of today, after even the legislation session, recommendations have not progressed beyond submitting the final report to the governor's office and the legislator. No legislative action resulted this session from the recommendation. So no implementation efforts are currently underway. We did have a webinar, our first webinar, and now we're going to have 2 more. I am going to put the link in the chat for those 2 webinars, and they're informational webinars and community listening sessions. So I really, and they're going to be in person and on Zoom, or yeah, Zoom. And so if you want to attend in person, lunch is provided. And if you don't, that's okay too. You can also just attend directly from your house, whichever one is more important. The first session was very informative, just giving us an overview of what the work group did. And we heard from a work group member on what's going on with Safe Supply. So Safer Supply, which was very interesting. And we heard some personal stories from people about overdose and Safer Supply. So if you get a chance to go ahead and sign up when I put the links in, please do so. It's a really easy sign up process. So, and then, oh, okay. And questions.
And we'll send out the presentation slides.
We will send out, and they'll be posted on the website as well. All right, and links for the meetings are going to be in the chat here in just a second. There we go.
Call for questions for Kelly. Okay. I think Tasha Fox is up next. Tony, you want to introduce Tasha?
Yeah, Kelly, thanks so much for the summary on SEDISA and Safe Supply Work Group. Just a reminder, I know we have new membership and new people attending, well, not new membership, but at least new attendees to SURSAC. The Safe Supply Work Group and SEDISA, Substance Use Disorder Intake Screening and Assessment Work Group, both were recommendations that came out of the SURSAC and were included in the Substance Use Recovery Services Plan. So as part of that, we wanted to provide kind of continuous updates since it ties directly to the plan that the SURSAC developed and submitted. And so just thanks so much, Kelly, for taking time to provide that update. We can come back when we have more information, and hopefully we'll have more information in the future. So yeah, next, Tasha Fox from Research and Data Analysis, which is part of Department of Social Health and Services, which is another Washington State agency in the executive branch, is joining us again to present some updated, more in-depth data as it relates to what we're seeing across the state based on the data that we have for simple possession. And so the idea for this was, you know, since SURSAC was enacted post-State versus Blake, and a lot of what the committee has been working towards is examining the intersection of substance use, individuals possessing controlled substances in the criminal legal system and our community behavioral health system. We wanted to have conversations and updates about what we're seeing in the criminal court system and criminal legal system as it pertains to new filings of unlawful possession of controlled substance and other relative charges that are associated with substance use and substance use disorder. So Tasha, thank you so much for all the work that you and your colleagues have done in supporting this data pool and making time to present an updated version of that data set here today.
Yeah, thank you, Tony. So I think I'm assuming that most people in this meeting, or a big chunk of you, were in the last meeting where we presented these initial data tables. So the ones that are on the screen right now will look familiar. I'll just go through them really fast just to kind of reorient everybody to this work that we've done. So when we started out, the first time we presented, it was just these kind of more simple tables with the counties and the charges by county, charges by month, and then the charges by court. And so these are just simple possession, drug-related charges. And so in this first one, it's showing unique interactions. And then in the second tab here, again, these are ones that we already presented, but this is showing the unique people. So, you know, someone might be represented in these tables. I'm sorry, in there's a little bit of duplication in these. So anyway, the questions that we got were kind of wanting to see some population weights by county, and just a few additional requests looking at accompanying charges versus standalone charges. So that is the new information that I'll be presenting today. But again, just this quick reorientation to what you've already seen.
And real quick, I think, can you scroll over to the left just a little bit? One question that we had was regarding knowing use in public. And so just looking at that table that's kind of in the middle, row J, you'll see there, I guess the table I and J summarizes the number of charges filed where it fits underneath that new, and then remember the RCW was changed through 5536 back in 2023 to not only include possession of a controlled substance, but also when somebody is knowingly using that controlled substance in public. And so one question that we've had and some conversations we've been having is, to what extent is that use in public charge manifesting, showing up in the criminal court system? And so I think seeing there that 971 individuals in state fiscal year 24 were charged with knowingly using in public definitely indicates that there is that charge is being filed within the courts. And so not only the criminalization of possessing a controlled substance, but just using it in response to treating a substance use disorder is showing up in criminal charges. Sorry, Tasha, go ahead.
Oh, no problem. Thanks, Tony. Okay. So I'm going to first go over to this one, these new tables, which this is showing the number of unlawful possession charges that just show, kind of splitting them up between the charges that had an accompanying offense with them. So for example, someone may be arrested and charged with domestic violence, and then they just so happen to have this unlawful possession of a controlled substance charge kind of added on to that. And then on the left side for these tables, these are the standalone charges. So the unlawful possession of a controlled substance being the only charge that the person received. So on the first table, we broke it down several ways. And this first one on the left, it's showing by county. And so also maybe I can zoom in a bit and then just slowly scroll down. And then if anyone has any questions or wants me to slow down or go back to a different table, just speak up, let me know. You can kind of see. And again, just a reminder, so some of these smaller counties where the numbers were less than 11, we suppressed just to protect client confidentiality, not necessarily clients, but to protect confidentiality. And so the totals at the bottom, you can see it's pretty much split in half. Sorry, was that Tony? Did I cut you off?
Oh, yeah, no, I was just gonna clarify, when we're listing the county there, it's aggregating by county, but it's a mixture of county courts and municipal courts within that county. Is that? So it's not just, when we say Spokane County, it's not just Spokane County District Court and Spokane County Superior Court, which are the county level courts, but also the municipalities that are within that county catchment area.
Yes, very good point. And you'll kind of see that in some of the other tables today too, that we'll get to. So we can see that, again, kind of split in half, about half of that being standalone offenses. And then looking at the same thing by month, you can see for fiscal year 2024, the breakdown by month of this row being the standalone charges, and then these where they were accompanied by another offense charge. And then I think this last table on the right is just showing the court type. So with the superior court charges, and I guess the other unknown, the numbers for the standalone charges at that level were so low that those are suppressed. But
Yeah,
then, oh, go ahead.
No, I was just saying, and that makes sense. That tracks because the Superior Court would not be able to file just a gross misdemeanor. It would have to be a situation where there's a felony, and then the gross misdemeanor possession would be kind of included in the entire case that's being charged. So that tracks.
Yes. Yep. So I know I went through that kind of fast, but are there any questions on any of these tables right now? Okay, well, just feel free to speak up if something pops up into your mind, but I will now go to this table, this overrepresented by county table. So this is a longer one. I do want to offer a disclaimer that this is just like Tony said with the last tables, these county counts are showing the full counties, and that includes a number of municipalities. And so these numbers should really be interpreted with caution. We didn't do any like in-depth statistical analysis in creating this table. So it's really just kind of a simple first look. It's not an in-depth analysis. So keep all of that in mind. And then also just pointing out that each county, each municipality, everybody, each department has their own case management system and data reporting practices. So there could be some inconsistencies by county in what we receive. So yeah, just want to make sure that we're clear that this table should be interpreted with caution. It might, you might see some counties where it looks like there's a huge cause for concern when maybe there's not. And when I get to the bottom of the table, there might be some counties where it looks like they're doing great, but that might not be the case either. So, just to kind of orient you to this table, this is showing the population of the county and then kind of like a weighted look at over and underrepresented charges. And so, but I want to point out too, the total charges and the standalone charges. So columns E and G are showing those charges that are just the drug possession charges, kind of like in the last table. So again, this is a longer table, but I can kind of scroll through it. I assume people probably have their own counties that they want to look at. So I don't think I need to like go line by line, but just pointing out some of these differences. We see Snohomish at the top with this in the red showing some of the overrepresentation of these charges by population. And as we scroll down, there's some of these counties here that are more of like, I guess, neutral, that we're seeing the percentage of charges kind of making sense by population. And then at the bottom, King County, this is what I was saying earlier, an example of this county that gets making King County look great, but there's several different municipalities in there. And also King County is it's so large that those individual municipalities kind of get lost in there. But yeah, Tony, is there anything else that you wanted to point out about this table?
No, just, and thanks for the reminders and the kind of caveats regarding the availability and the data set. There are working with data that we receive or that RDA receives, just noting that there are more than likely some jurisdictions that aren't reporting, or it's not necessarily a complete data set from what I understand.
Yep. Yeah, lots of inconsistencies and yeah, it can be a little challenging, but this still gives you a pretty general overview of what we're seeing. I think I saw a hand raised and then it disappeared. So I just want to make sure I'm not skipping over.
Oh, no, there
Hi.
is a hand.
Tasha, this is Scott Brandon with LEAD. I just wanted to add to Tony's thanks for the work that you did on this and reiterate what you just mentioned about how some jurisdictions can get lost, especially in some of the larger counties. And this gives everyone a really good chance to go back and take a look at your own local data to help identify gaps and see areas where some added focus may be beneficial.
Yeah, absolutely. Thank you. Okay, so just to show you kind of an example of when we say each of these counties has lots of different levels. So I'll use Thurston County as an example. So this Thurston County, I think, okay, just going back here real fast. Sorry. Let me find it. So you see here, that's the Thurston County line. It's one of those, not really remarkable trends in either direction. But looking at this table, you can see just all the different court types and jurisdictions that go into that. This is a very long table where we have, data is included here for every county. It's very, very long, just to kind of like show you. So I don't think you'll want me to scroll through this one slowly because that would take quite a while. But if anybody wants me to scroll to a specific county to look at something, just let me know. But yeah, you can kind of see just the variation within each county. So just another thing to keep in mind. All right. Are there any questions about either of these tables I just went over with the counties and the over and under representation?
No, Tasha, just noting in the chat real quick, Rep Davis asked, can those tables be shared with us?
Yeah, I think that these can. I will double check. I know at least some of them can. I'll just make sure that we don't have any in there that are too sensitive, but I think it should be fine to send that out to the committee. Yes.
Thank you. And then Kevin Walker, also from DSHS Research and Data Analysis, indicated a big reason King looks that the way it does is simply because of how large the adult population is. So even though King makes up roughly 14.5% of total drug possession charges in the state, because they also make up nearly 32% of the adult population, they appear as though they are doing really well. That's a good point, though. The population we're using, is it just adult?
Yes.
Because we're including juvenile charges. So I wonder if maybe we should, or kind of look to see if that needs to be revised to include youth population. Because if we're including charges at the juvenile court level, then it's going to be skewed, right?
Yeah, that's a good point. So yeah, this is showing ages 18 to 64 years. I'm not sure with we'd have to look into like the juvenile charges that are included and what that represents. Because I know that I know that they've changed the ages in recent years for who can be committed to a juvenile facility. I know that's not what we're talking about, but oh, go ahead, Kevin, speak up. He's going to have better answers than I do.
No, I was going to say, can you toggle back to, I think it's, we'll go with the first tab where it's kind of breaking it out by court, because then we'll be able to see how many of these charges would be juvenile. Yeah, so 468. So if we do include the juvenile population, that would skew the numbers even more in a way that is going to be less useful. I mean, for that current, heat map that we're just showing, just because of how few cases there are.
Mm-hmm. That's true. Okay. And I think the last set of tables is just, we were asked to look at the drug paraphernalia charges specifically, to just kind of break those out and take a quick look at them. Lots of suppressed numbers in this, just because for several counties, these numbers are just too low to include. But Tony, I think you had asked about the drug paraphernalia breakout. Do you recall if there was anything specific that you kind of wanted to highlight in these tables?
I think it was in response to also within 5536 back in the 2023 special session, the drug paraphernalia, I think section 2, or I forget which section of the bill, but there were changes in terms of allowances at the county level to monitor harm reduction programs and drug paraphernalia charges. The RCW was amended to some extent. I don't remember exactly what, but it was a question that came out of the last time we presented these data, is exactly to what extent are we seeing the drug paraphernalia charges being filed across the state, and are those increasing? And it looks like they are. Similar to the simple possession, you can see for this state fiscal year 24, going from 28 charges a month up to 108 charges a month. The majority of those are happening at the municipal and district court level. And when you go to that table that indicates the county, you can definitely see some outliers there in terms of the frequency of those charges being filed within that county. So can you scroll down that? So it looks like Benton and Pierce, Thurston, definitely, an interesting variation between counties in terms of how often those charges are being filed. And then what's the last table to the right?
It's just showing the actual charge name, the type of drug paraphernalia charge that we're seeing most frequently.
Yeah, it's interesting that the possession of drug paraphernalia is around 304 count, and then use of drug paraphernalia is at 262. I don't know enough about the difference between those two RCWs as to, I guess, one, like the law enforcement officer would have to actually see the individual using the drug paraphernalia for it to be filed or charged by the prosecuting attorney as use of drug paraphernalia. But I wonder if that coincides with the, additional catchment under the RCW for possession for public use. And so if those charges are kind of being filed simultaneously, where if law enforcement sees somebody using in public, they're charging them for both the knowingly use of a controlled substance in public and the use of drug paraphernalia. That's interesting. I don't know. I know we have some attorneys on the call. Well, maybe not. I don't know. Let's see. Yeah, Chad and John both. Oh no, John's not here, but Chad Enright, committee member representing WAPA. Not sure if you have any anecdotal experience that kind of speaks to that, or if you wanted to speak to that at all.
I would say it's unlikely you would charge both of those. At least in my county, you wouldn't charge use and possession of paraphernalia. I think you would just charge one or the other. They seem like same criminal conduct to me.
Oh, thanks, Chad. That's helpful. It is kind of double dipping in a way. And John, sorry, you are here. Didn't mean to overlook you. I was scrolling through 700 70 names real quick. 700, that would be a big meeting. 70 names, and and missed you. Sorry, John.
Not a problem.
And I think that is it for the updated tables that we have today. Are there any questions, or does anyone want me to go to a different tab to kind of revisit a table or anything like that?
Just noting that in Kitsap County, where Chad's calling from, the possession of drug paraphernalia is suppressed because it's so low. So.
Yeah, and thanks. This was a group effort. We've had lots of meetings across HCA and other agencies to discuss this, and lots of really good work by Kevin Walker and RDA. So thanks to everybody who's helped work on these. I think that's it from me.
All right. Thank you, Tasha. Any last questions for Tasha? Okay. I think we have an update coming up, RMP highlights. Do we have a presenter for that?
We're a little ahead of schedule, but maybe somebody is here already. And while we wait to give them an opportunity to unmute, just thanks again to Tasha and Kevin for helping pull together those data and presenting. One thing we are talking about for a future meeting, probably not in the next couple of months, but sometime this year, is to bring in race and ethnicity and other demographic data for those data set. And then bring that back to the committee. And so probably part 3 of 3, and we'll. In the meantime, if the committee has any recommendations or has any follow-up questions, feel free to reach out to me, and I can loop in Tasha, and we can kind of go from there. But really appreciate it. Cameron. Yeah, Cameron, is Cameron here?
I am. I'm on.
Oh, wonderful. Cameron Fordmeyer from the Greater Columbia Behavioral Health Administrative Service Organization is here today to talk about efforts regarding Recovery Navigator program in the Greater Columbia region. And so I will pass it over to you. Thanks, Cameron.
Yeah, thanks. So it's a little impromptu. So this is freestyle on my part because we had Shireen Hunt with Merit, who is doing our pretrial diversion services in Benton and Franklin County, had an emergency contact. She's also the executive director for Merit. So she had some immediate situations to do. So hopefully we can get some numbers on pretrial on a separate or a further meeting on SURSAC, and we can actually get you those numbers. But just wanted to provide some updates on our pretrial with the proposed 20% cut. So go ahead. Oh, sorry. Okay. I thought somebody said something. So right now, our pretrial is going to take priority. So with the 20% reduction, we've had to make sure that that team stays whole and that the people who are under those are still there. So some of the changes that we're looking at modifying when it comes to RNP, specifically around pretrial diversion, is providing that be target population and reduce some of the allowed expenses that we were for social referrals. And so we had put quite a bit of funding for client care costs to prevent barriers for accessing those treatments. And depending on the funding, we will have to take a look at what we're going to modify. As well as that, we've also had to modify some of our teams. We had 7 total teams, but with the reduction, we will probably have to modify that to 6 teams covering the same area, but just reduce the amount of staff that we would have to do that. And then again, we're also going to be putting a couple different amounts based on individuals to receiving care. And so before we had not capped the amount of individual spending on somebody, whether that's housing or access to food insecurities, basic needs, but we're looking like we're going to have to modify an individual cap for people and as well as a yearly cap on funds used for that. So those are about the updates on that. We did have a whole presentation on numbers for pretrial diversion, but hopefully we can get that to you soon. And I did want to take the time for those of you who have not registered to please register for the Deflection and Diversion Summit, May 22nd and 23rd. So that'll be on Thursday and Friday. We are hoping to get all of you to all key stakeholders so they can recognize all of the deflection and diversion options across the sequential intercept model and hopefully pick which ones, if you have gaps in that, or there are some counties that still have very little to no deflection and diversion options. So if you can figure out whether you're using public safety sales tax or 1/10 of what's right for your community and how to plug that in and learn how to fund, implement, and sustain those programs. So that's about it for me on my freestyle session.
Cameron, do you have the link for that presentation to attend that presentation?
Sure, I can send the registration link. I'll put that in the chat.
Thank you so much.
All right, Rep Davis.
Thank you, and thanks so much, Cameron. I just wanted to kind of highlight, so Greater Columbia has been doing an incredible job with RMP from the jump, but one thing that I think is relatively unique that's happening in that jurisdiction that I wanted to highlight. So through Cameron, I was able to get connected to the Kennewick municipal prosecutor, who has totally gone gangbusters related to using RMP for pretrial diversion. I think just to refresh everyone's memory, so RMP is LEAD. LEAD was obviously conceptualized originally as a pre-arrest or pre-booking diversion, not a pretrial diversion. And not in the first Blake Bill 5476, but in the second Blake Bill 5536, we created that as an explicit pretrial diversion option with the recognition that there was going to be more charges because we were removing the required pretrial we were removing the required multiple pre-arrest diversions, which we had in the first Blake Bill. So anyway, but the Kennewick municipal prosecutor has just done an extraordinary job and has developed a system in concert with Cameron and service providers, and they've funneled, I don't have his numbers in front of me, but hundreds of people that are charged with the same charges that we were just hearing about. And it's been enormously successful. You know, shocker when you actually provide peer services that are person-centered and harm reduction based and rooted in, you know, human dignity and hope, people actually do well. And the prosecutor was describing, you know, people in their 50s who were crying, saying they'd never been offered treatment before, despite this extremely extensive criminal history. And so I've seen, to my knowledge, and maybe that's something that we could get perhaps a presentation to this committee about at some point. It's my general understanding that very few jurisdictions have really taken up RMP as a pretrial diversion. It's mostly still being used pre-arrest or pre-booking, which is great. But for jurisdictions where we're seeing a lot of charges, ideally, those people would be offered diversion, but it takes some work to figure out the actual paperwork and the mechanisms. And so I have been encouraging other jurisdictions to talk to Laurencio, the prosecutor over there, because he created all the forms and he's happy to share with anybody. And he created a list of charges that are sort of in and charges that are out. Charges like domestic violence and DUI being out, charges like criminal trespass, malicious mischief, theft 3 being in. So anyway, it's just very, very encouraging to see that in, you know, Eastern Washington, no less. And and they've been super pleased with it, and it's no cost to their jurisdiction because RMP is funded by the state. So a bit of a pocket of excellence, and I'd love to see us point other jurisdictions to that, or maybe even have, you know, Laurencio come present to this group and invite others to listen and learn. But big credit to Cameron, because that's in his region and he was heavily involved in setting that up.
Thank you.
Thank you. Any other questions for Cameron? All right, Tony, anything from the room?
No, I appreciate the impromptu update on how Greater Columbia is looking at the 20% reduction in R&P funding and how to account for that. And hopefully we can have Shireen and Merit Resources come to a future meeting to present some of the good work that they were planning on presenting today. I do want to just kind of flag real quick, because when we talk about a 20% reduction for R&P, it is significant. R&P was originally funded at $20 million a year, and then it went up to $24.5 million over the course of a couple of bienniums. The 20% reduction is off of the top of the entire 24.5, which brings it down to 19.6. So really, R&P is reduced at $400,000 a year off of its original base funding, because it started at 20 million, went up to 24.5 thanks to increases from the legislature, and then is now down to 19.6 million a year. Still impacts, because that 4.5 million was used to expand services. But just wanted to provide that historical summary of how the funding has changed since 2021 when the program was first enacted. I think that context is important.
All right, thank you. So it looks like we are on to public comments. So if we have any comments from the public, please go ahead and raise your hand virtually here, and we will get your comments. Again, time for public comment, if you would like to make one. All right, see no hands. So Kelly, you want to?
Look, Blake, real quick, just wanted to flag, like, the public comment time isn't necessarily just in response to the content today or the presentation we just had or any of the presentations today, but really a time, just as a reminder, for anybody that isn't directly tied to the committee, to share information, to share experiences, to share updates about what they're seeing in their community. And so just really want to encourage, because we do have, pretty good attendance every month with this meeting, to bring that, to feel free to unmute and share and help ensure that we're aware of, what is happening across the state. So just really want to encourage those that are non-committee members and committee members. Obviously, we always want to hear from our committee members and what's happening in their areas of expertise as well. But just really want to encourage the attendees that come and spend 2 hours with us every month to bring their experiences and share what they're seeing and what ideas or how fentanyl use, drug use has impacted their community with the group. Thank you.
Thanks, Tony. So any comments? Looks like we're good for today. But yes, please do comment about anything you would like to. Kelly, I'm going to turn it back to you.
All right, thanks so much, Blake. Here again, so I just want to go over June's agenda. This is what it's set as right now as a draft. So it doesn't mean this is not the final one, but this is where we're at right now with June. And it's welcoming. It'll be myself and Tony with doing HCA announcements, and then Blake running the committee member announcements and public comment. Brianna Peterson will be presenting the Recovery Navigator Program quarterly report, and then research and data analysis presentation on current state assessment. Tony, do you know her name? I put TBD because I forgot her name.
Yeah, it's Katie Bittinger.
Okay.
Yeah, Catherine Bittinger will be sharing work that RDA has been working on for the past year in updating Washington State's current state assessment for substance use disorder. And so it touches on a number of different metrics, but focuses on looking at treatment rates across the state, looking at some outcomes associated with substance use disorder treatment. And so really good work that actually originated with a grant that the Healthcare Authority received through the Center for Medicaid Services back in 2019. And so we did, HCA partnered with RDA to do a current state assessment to really get a sense of what's happening with substance use disorder, rates of use and rates of treatment across the state. And then that work was basically updated. And so it's kind of a revised current state assessment. So should be a really good conversation. Go ahead.
And then after that, it's just me at the end reviewing next month's agenda. So it'd be July. So yeah, we'd be talking about July's agenda. And so, is there any comments or questions for this right here? Does anybody have any questions?
Just flagging a couple of suggestions for future meetings include an update on Washington State's efforts to create a bulk purchasing and distribution project for naloxone. That came out of the conversation about the ledge session updates. And then I also heard Rep. Davis suggest maybe having the Kennewick City prosecuting attorney come and share experiences regarding creating a pretrial diversion program in the city of Kennewick and Benton County. And so we'll try to fit those into future agendas. I think we may have some time in June. Although I know the RNP quarterly report updates take a while, so we want to make sure there's enough time for that, since that's specifically tied to requirements of SURSAC. But just committee members as well as attendees, please feel free to reach out to Kelly if you have any recommendations, questions, or suggestions about content presenters for future meetings. Is that it?
That the agenda's over.
Well, I guess I might as well close this out as well then. For the first time in I think at least 2 years, we're ending early. So there's something for that. I hope everyone appreciates the 18 minutes that you have back. And so I know it'll help us allow us more time to kind of debrief and talk about today's meeting as well as plan for future meetings. I just want to thank again those who shared their time today to present updates: Sean O'Neill, Tasha, as well as Cameron, and also the conversation, the questions, the comments, the feedback. It's so important to make sure that this time is used in a way that is beneficial for everyone, but also helps us to look at the current state of Washington and how it's responding to people who use drugs, and the overall goals of this committee as it pertains to ongoing monitoring in State versus Blake. And so really appreciate everyone's time. And when's the next meeting? June? Should have a calendar more. June 2nd, as long as that's not a holiday or anything. So June 2nd, we'll see you back then, June 2nd at 9 a.m. And thanks again.
I would now be ending